One of the world's leading clinics for the treatment of long COVID is at the Mt Sinai Hospital in New York. In this film, Dr Asad and I talked to Dr David Putrino, Director of Rehabilitation Innovation, about the groundbreaking work they're doing to treat long haulers. Long COVID is a complex puzzle, but one part of it, dysautonomia, is responsible for many of the myriad symptoms patients face, and it's here where Dr Putrino's efforts are focused. We discussed the role of physical rehabilitation, breath work, how to stay inside your energy envelope, and just why the medical establishment takes 17 years on average to get treatments from bench to bedside. Hope you find it helpful. I was wondering if you could tell us a little bit about your background and how you came to be treating long COVID patients.
Sure. Well, thanks so much for having me. So I work at Mt Sinai Hospital in New York, and I'm the Director of Rehabilitation Innovation. By training, I'm a physiotherapist in the UK. I'm a physical therapist in the US, and I have a PhD in neuroscience. The biggest barrier we face in health technology in the United States is to take something from bench to bedside. On average, takes around 17 years, which is just a crazy number. And so I came to Mt Sinai with one mission, which was make that number smaller. And along the way, you know, what my role entails is investigating new technologies, investigating new therapies, and developing new therapies. And this has been going on well pre-COVID. And so when COVID hit, one of the first things that my team did was we recalibrated an application that we were using to track post-discharge stroke survivors, and we focused it more on acute COVID symptoms. And we very rapidly became the health system's, official remote patient monitoring service for acute COVID patients. As we started to monitor patients over the course of, around a month, we started to notice that a handful of our patients at first, but then more and more, just weren't getting better. They were saying, well, the cough is gone and I don't have a fever anymore, but I'm extremely fatigued. I have palpitations. Everything that we all know now to be sort of long COVID lore is what these people in April and May of 2020 were independently reporting to us. So it wasn't like these guys had formed a cabal and were already planning, hey, we'll text this into the app. These were human beings who have never met one another coming back with identical symptoms. Another thing that makes me fortunate in my role is that because innovation often requires stepping outside of one single scope and talking to lots of different people, I have a really wonderful team that's interdisciplinary. So, from the outset, as we started seeing these symptoms on our end, we weren't diagnosing anything, but we were thinking, wow, this looks dysautonomia-like. It looks a little bit like, this condition dysautonomia, which is characterized by the autonomic nervous system being thrown out of balance and starting to get all sorts of full system symptoms that are random, hard to catch in their tracks, and somewhat resilient to traditional tests and lab tests. You don't really see that. There was a team of us who have experience in dealing with dysautonomia, a wonderful team of people that came together and said, we've got to put together a treatment for this condition.
What was it that surprised you the most about the way that these patients were presenting?
For me, the most shocking and surprising element was just how debilitated these patients were. So, like I said, a few of us had experience with dysautonomia. Amy had been working with patients who had dysautonomia for many years and was able to put them, no problems at all, straight onto the Levine protocol, which was successful in rehabilitating a vast majority of her patients. There was not a single hope in hell that we would have to put our patients on the Levine protocol at their level of how debilitated they were and have anything but a flare occur. That was just not not an option. And so that was probably the thing that really scared me, was the level of severity that we were seeing, the level of debilitation that we were observing.
You obviously were observing a lot of dysautonomia. Do you think that was because it is omnipresent in long COVID patients? Or is it because you were being filtered through one of the three phenotypes, the other ones being the kind of deconditioned hospital discharge patient, the second one being the sort of target organ damage with the sort of myocarditis or spinal cord problems or the urticaria, although obviously there is overlap, you can have more than one type. Or would you say that dysautonomia is just present in almost all patients with long COVID?
No, I'm really glad that you brought that up, because 100%, our filter was very much through the app that we developed. We were seeing non-hospitalized patients. So what happened was we managed the care of thousands of COVID cases, and we were quite proud of the fact that we managed to prevent hospitalization in almost all of them. There was probably a few dozen of those thousands that we couldn't conservatively manage with home health care, and we had to get to the hospital. Everybody else was managed conservatively, successfully. And so that was the subtype we were seeing. Now, because we collaborate with Mt Sinai's Center for Post-COVID Care, and we're an affiliate of that center, we also see the other phenotypes, which are exactly as you pointed out. These are individuals who had extremely severe disease, were hospitalized, now have pulmonary fibrosis, and they need pulmonary rehab. They don't need autonomic conditioning therapy. They need something that has good evidence behind it and is well validated, and we can know what to expect in terms of their response. We see people, they see people who need cardiac rehab and and everything in between. And so yes, we're definitely, I'm not saying that in the PASC universe, which is what the NIH has dubbed this, the post-acute sequelae of COVID, everybody has dysautonomia. That is not the case. And I'm still, somewhat uncomfortable saying dysautonomia, just as a label, because I've been unhappy. Everyone seems to want to label this group, and I've been unhappy with the labels that they've been offered. So we've still been kind of saying, hey, dysautonomia, this looks like dysautonomia, but it's an entirely unknown disease process, and we still have a lot to learn before we give a formal diagnosis beyond long COVID.
I mean, that's really interesting. And I think maybe the distinction here is between saying the autonomic system is dysfunctional and what we understand dysautonomia pre-COVID to mean. And maybe that's where the distinction is. I was just going to ask, what treatments did you, or rather, how did you begin to treat the patients you were seeing, and how has that evolved over time with how you've sort of seen them come in, or how you've seen the results? Could you just tell us a little bit about that?
Yeah, absolutely. So initially, when we first started seeing patients, we were already thinking along the lines of the Levine protocol, but just from listening to our patients, we were already hearing that it wasn't going to fly. It was far too intense. So with some of our first, I would say, brave collaborative patients, we really just started trying to understand on an ad hoc basis how much was too much and how much was not enough. Using any sort of pacing guidelines, using heart rate as a guide was just not going to work, because heart rate in many of these patients was just too erratic. So we started using Borg. We started using perceived exertion. So you tell us where you're at, and then we're going to find a rate of perceived exertion that does not cause flares, and that's where we're going to start. So So it was in the early days a little bit of trial and error. The other thing that was really valuable was getting to work with Josh Dunst from Stasis, which is Josh is a founder of a breathwork company, and he's a veteran and has spent some time in Navy Special Ops. And when I started, we were working together actually because he was a collaborator on some of our high performance projects, working with athletes and teaching them about breath awareness and things like that. And when I started chatting to him about some of these patients, and I was just like, hey, got any ideas? He said, this sounds like hypercapnia that we see in Air Force pilots who have been pulling a lot of G's. And I wonder if their CO2 levels are low. And we started looking at CO2 levels using a capnographer, and sure enough, they were hypercapnic, or a large proportion of our patients had, resting hypercapnia. So, we're expecting 35 to 45 millimeters of mercury at end tidal CO2 levels, and we were seeing 25 to 35. Just sort of left shifted, not a whole lot, not so much that we're like, oh my God, this is dangerous, but enough that it, we took note, and we said to Josh, well, do you have a breathwork protocol for this? And he created one, and a lot of our patients started doing it and immediately felt better. Now, it's not like, oh my, like we cured them. The way that most people describe it is the breathwork takes the edge off their symptoms. And so we saw that, and we said, okay, well, this is great, because if we can move the needle a little on the symptoms, we can use this as prehab and then get our patients into the autonomic conditioning therapy when they're feeling a little bit more ready to experience even a small level of exertion, because the lowest level of our autonomic conditioning protocol starts them out at a 1 to 2 on the Borg. So we're working at a very low level, but even that felt like a big stretch for individuals who felt like they had no control over their symptoms. And one of the things that we felt was really helpful with the breath work was giving people a go-to when they're feeling strong symptoms that actually seemed to, have a meaningful effect in the moment.
I was wondering if you could just give us some definitions for Levine and Borg. And on that sort of Levine sort of plan that you were talking about, when you are able to, once you've done the prehab and able to start doing the rehab, what sort of outcomes have you seen from patients who have been able to maybe start some of the things that they weren't able to before?
So Levine / Levine / who knows protocol, is one protocol that is used for dysautonomia, and it's this graded exercise therapy. So it's slowly it slowly steps you up over time into different levels of intensity. Now, it's worth mentioning that we are not using strictly the Levine protocol, and we've actually, just for clarity's sake, we've just called it, what we're doing, autonomic conditioning therapy. And so we've started at a very, very low level. We start typically, in most cases, we'll start recumbent. So you're lying flat on your back and you're performing leg movements. And we use the Borg scale initially to work at a level that we have found is acceptable to patients with long COVID, in that it does not go on to cause flares. And so the Borg scale is a really well-validated scale of perceived exertion. It really is just, tell me how hard you feel you're working right now in this moment. And so what we work to do in the earliest stage of the autonomic conditioning therapy is work at 1 to 2 on the, out of 10 on the Borg scale. So really, these people are feeling like they're doing barely anything at all. And and that's obviously, well, that's often a concern of our patient population, because many, again, as I'm sure everyone knows, many long COVID patients were previously fit and healthy. They were, they'll tell you they were running marathons. They were very active. And so they're laying flat on their back, moving their legs up and down, and they look at you like, this is kind of nothing. I don't, this isn't, I'm not doing any work here. Like, and we, let them know that this is part of the process. And then you slowly increase the intensity of the work that you're doing as the autonomic nervous system gets more comfortable with challenge. So this is really the idea behind these therapies is your autonomic nervous system's been knocked out of balance. And now every time anything that is even perceived as a small challenge throws it into overdrive, and you have this intense body reaction that can be, a bowel reaction, a consciousness reaction, sweating and heart rate, and, all of these very intense attacks. Or on the other hand, you can just get this extremely exaggerated fatigue response in response to a, inordinately small amount of exertion, or comparably small to what you're used to. So the whole goal behind this autonomic conditioning therapy is to slowly knock the nervous system up into a level that it can tolerate. We're currently at a point where we've discharged a few dozen individuals from care, meaning that they've told us that they feel close to or where they were pre-COVID, which was a huge milestone for us that we only really hit March, April of this year. If you would ask, well, I think a reporter did ask me in January, and I said, not a single person has told us this thing yet. So the floodgates opened, and that was a really good feeling. And that was all credit to, Jenna Tosto Mancuso, who's this incredible autonomic therapist that I was telling you about, who did a lot of the pioneering work here and really worked hard with a lot of patients to get there. But on average, the numbers we're seeing is 100 days of therapy. So it's engagement in the program for on average 100 days before we get to a point where we feel comfortable discharging. And I will say, on a less triumphant note, I will say that we've since had one patient come back to us with a severe flare. We discharged her to the point where she was jumping on Peloton and really, pushing herself. And 5 months after discharge, after being completely fine, she had a pretty severe flare. So, I will say that we got to keep an eye on this, because we've been saying this from the beginning, this, dysautonomia-like. This could be, dysautonomia secondary to autoimmunity, or it could be dysautonomia secondary to something else. And that's the next question, is why did this person flare after 5 months, and how do we get it back on track?
So you mentioned the Levine protocol and how it's sort of a form of forget, and I can immediately see the goosebumps going up on some of our viewers' skin, but it's heartening to hear that actually what you're doing is keeping them within the energy envelope,
Yes.
and really gradually building up that exertion. But what is your approach to PEM? I'm assuming that a lot of, well, if they've got dysautonomia-like features, I'm assuming most of them will have PM features. So how do you approach it?
Yeah, and I kind of mentally kicked myself when I said graded exercise, because, I get that as this has gone on, exercise has become a dirty word. And that's really a shame, because, really what we need here from our health professionals is a really solid understanding of how conditions like this get exacerbated and how they get flared. I can't tell you the amount of times I've face-palmed about hearing about an initial assessment including a 6-minute walk test, or an initial assessment including a cardiac stress test, and then on top of that, having physicians say, well, they made it through the 6-minute walk test, no problems. They made it through the cardiac stress test, no problems. I'm like, yeah, did you check on them the next day? No. well, then, you can't say no problems, because this is how the autonomic nervous system works. And, what you're demonstrating is a fundamental misunderstanding of that, not good, good clinical practice. So, from our point of view, certainly we flared some people early. But like I mentioned, we really had a wonderful collaborative group of patients who were just comfortable with, where we said, listen, here's our working theory, and we're going to work with you. We're going to make sure that we get you to a point, we're not going to give up on you, but initially we might make mistakes. And, it's up to you to report to us what's going on, so that we can push through. And so we had the basic principles down. So, and we knew about PEM, and we knew, post-exercise malaise. I guess we haven't said it out long form, but post-exertional malaise, I should say. My God. So we knew the basic principles. So we started off incredibly gentle, because we were already hearing, this is, we had these former athletes telling us that walking downstairs to get their groceries left them exhausted for 3 days. So we knew that Levine was not, the starting point of Levine was going to be totally inappropriate. And that's where, so what we did was we started on the extreme low exertional end. And okay, did you get any bad reactions to that? No, but we're probably not helping you. And then we sort of pushed up to see how hard, and again, just learning to use Borg rather than heart rate, because heart rate was just becoming an unreliable measure. These were all the things that we learned, and that's how we adapted our approach. And then once heart rate started being a bit more stabilized, then we can use heart rate to get people into zones. But initially, using Borg was far more reliable and far more safe. And so I don't know how to say it other than, trial and error, some wonderful initial patients, and a lot of patients TS on our end.
You said earlier on, David, that the kind of people with cardiac compromise or respiratory compromise, they go through a different stream. I mean, sometimes it's obvious who those patients are because they've been in hospital, but for those where it might not be as obvious, what sort of pre-screening is taking place, and by whom?
So one of the first things that we are doing in our work is making sure that everyone gets an echo and a clearance to engage in our autonomic conditioning therapy by a cardiologist or similar medical professional, because, I can tell you that, after about, 1,400 patients have come through, I can say around 0.5%. So it's not a huge number, but it's enough to make us scared, that have shown up with a serious cardiac pathology. It's not COVID related. It's, you have a really serious pericarditis or, myocarditis. And we're just so glad that we took that extra step to make sure that everyone got cleared from a cardiac perspective, to make sure that these individuals were appropriate to begin rehabilitation. Because, I guess I don't need to tell you guys at all, but there is that tendency in the health system to try to create these very cost-effective pipelines of care as quickly as humanly possible. It's like, so if anyone comes in with this constellation of symptoms, get them on a treadmill, get them on a, start the autonomic conditioning therapy. And especially when you have a condition with invisible symptoms, meaning that, we can't see them on conventional testing, there's even more of a tendency to say, okay, well, let's not worry about all of this other process because it's just going to show up negative. What are we going to tell the insurers, et cetera, et cetera? Just get them straight into therapy. But from our point of view, cardiac clearance is the one thing that we won't compromise on.
So I had a question to follow on from where we got up to, which is, given that there are millions of long haulers all around the world, and not everybody can come and see you in New York, what are the practical tips that people watching this can do that you have seen make big differences for your patients?
Some of the most important things that we've been advising is there are autonomic specialists out there, and there are cardiologists and neurologists who specialize in dysautonomia out there, and so in a lot of cases when people have just had trouble getting care where we're at, we try and find a cardiologist that will perform the necessary testing and speak to them about dysautonomia. We also just provide education around the fact that the Levine protocol is typically too intense. So finding ways to lower the initial intensity to get going is a practical tip that we give. In addition, the breathwork programming is pretty ubiquitous and for the most part easy to sign on to and get involved in. So we've just been handing out that Stasis link wherever possible. In terms of behavioral health things, we've really just tried to put a lot of awareness out there about paying attention to symptom flares and trying to trace back things that cause the symptom flares. So although there's no one thing that helps everybody, because the autonomic nervous system is so diverse and individualized, understanding that if your blood pressure is fluctuating and that's causing a lot of your symptoms, the fact that wearing compressive socks, things like TED stockings, can make a big difference in stabilizing blood pressure. If heat is one of your triggers, paying attention to the weather where maybe you didn't pay attention to the weather before, and understanding, hey, if I don't plan out my day to be in cool and non-humid environments, my heart rate is going to increase, and that's going to trigger an autonomic episode. Understanding that big meals, will sort of switch you into a parasympathetic mode, which can again cause this massive attack of symptoms, whereas planning out smaller meals, making sure that that the meals that you're eating are easily digestible, so that your digestive system doesn't need to do a lot of work, which causes a rush of blood, which causes an autonomic response. So really, piecing together people's days, understanding what is triggering them, and finding ways to avoid those triggers has been, a lot of the basic advice.
You mentioned that you try and share information about the stasis breathing. I was just wondering if you could just tell us a little bit about what the stasis breathing is and where people can sort of find out more about it.
Yeah, absolutely. So, oh my God, the website is, I believe, stasishp.com. So they can just jump on that website to take a look. Sign up is completely free, where you are just basically onboarded into a series of resources where they take you through a series of videos and show you the particular breath work that they've been having the most success with so far, and give you a number of different breathing strategies for different scenarios that you might find yourself in. So, things like box breathing, if you're finding yourself in a highly sympathetic state and you need to calm your nervous system down, box breathing is, according to literature, one of the fastest ways to regulate and bring yourself into a parasympathetic state. So it just takes you through a bunch of very well evidence-based breathwork protocols. These are pretty self-explanatory, so it was very, very good of Stasis to do all of this free of charge, but it was simple enough for them to sift through the literature and provide the resources that were mostly relevant to long COVID patients. And then, if you do want to work with a breathwork expert, they have a series of certified breathwork coaches who can work with you one-on-one, and you can make appointments and do all that sort of thing all over the world. Because as we've seen, some people do have paradoxic breathing patterns. They've started to develop abnormal breathing patterns as a result of the chronic shortness of breath that they're experiencing, and sometimes even just the panic that they're experiencing around not getting enough air in or feeling like their chest is too tight. And so sometimes working one-on-one with a coach is helpful because, they're well-trained, extremely experienced individuals who can walk you through everything that you need.
Thanks, David. So you mentioned earlier on a little bit about what happens in autonomic conditioning therapy. So you're starting really low and slow. Can you share any more detail about what the patients undergo in ACT?
So in addition to a lot of supportive advice around energy envelopes, around identifying triggers and identifying things that can ease symptoms when symptom flares are occurring. The therapy itself really is just very slowly progressing, conditioning therapy. So typically in the first phase, we can get people through the first phase on average in around 4 to 6 weeks, where we're laying recumbent and just gentle movements of the legs, gentle movements of the arms sometimes as well, sometimes gentle movements of the arms and the legs, but all sort of staying within that one, that one range of 1 to 2 on the Borg. Then we move them into a second phase where we start to bring them up a little bit. So if they can tolerate it, it will, we'll sort of bring the back of the back of the bed up, and they're in a sort of a half-lying position. If they can tolerate it even more, we might get them full up into a long sitting position and start working them slightly harder. And then over time, we move them into a third phase, which at that point, we're pretty much at the Levine protocol. At that point, now we're moving into heart rate zones. Now we're getting them on a bike if we can, or getting them swimming if that's more comfortable for them, because many people who feel ready for aerobic activity still don't quite feel ready for the upright position. So swimming has been really helpful in, maintaining an easier heart rate, because, they're laying flat and they're, there's blood in their thorax, and then from there we slowly progress up, in a symptom titrated, as Jenna would say, manner.
I'm going to throw a real curveball in here quickly. As a neuroscientist, this may or may not help you with what you think is going on with regards to brain fog and cognitive dysfunction generally. Do you have any sense of what you think might be causing it?
This is a really challenging topic. I think that in the dysautonomia community, cognitive deficits are quite rare. Not quite rare, quite common. People with dysautonomia will often report that their cognitive performance fluctuates with their symptoms, and it does make sense that if your body is switching between autonomic states, that you're going to have a lot of difficulty with higher level cognitive function. I think, one of the ways it was best described to me by my wife, who has dysautonomia, is, she feels like she's spending so much cognitive effort when she's having a really bad day just being upright and being present, that anything else is just knocked down significantly, and so I think that from one perspective, that idea tracks. There's a lot of reporting of this in the dysautonomia literature. I feel encouraged by a lot of the post-mortem COVID work that has been done, that has shown that it's very, very rare for COVID-19 to get into the brain. And I've also felt encouraged by the fact that as people have recovered along our protocol, they've also reported that they feel less like they're having brain fog days, and that the brain fog symptoms seem to co-occur with the dysautonomia symptoms. So there may be other causes, and long COVID is definitely more than one thing. But for now, it does make a fair amount of sense that we're seeing this co-occurring with a dysautonomia-like condition.
This is groundbreaking work, but it's a shame that it's sort of not more widely known and publicized, and dare I say, published. I believe that's been difficult for you, hasn't it?
Oh yeah, I mean, scientific publication. So again, I feel somewhat blessed that I work in innovation, where I always used to tell my students that on average it would take 4 or 5 years for an idea of mine to even be considered in mainstream science. So it's like, you could set your clock to it. It would be like, the first time you present the idea, this is stupid, who are you, go away. The second time you present the idea, 2 or 3 years later, maybe, but probably not. And then the third time, year 5, oh my God, this is brilliant, this is groundbreaking, whatever the case may be. And it's funny to watch that happen. It's funny to watch it on citations on papers that we publish, because we'll publish these papers and they won't get any citations, and then 5 years later they'll get 100 citations immediately, because the scientific literature is finally catching up. So publication is always going to be tough, because science is a club, and I really don't mind saying that, because it's the truth, and I think more people need to say it, and so it really is a bunch of people saying you can't sit with us, and it's a zero-sum game. If you publish something, they got scooped, and that's just not in the public benefit. So we've been working on pre-publishing as much of our work as possible. There was one particular paper that we published that was sitting in a +1 editorial office. It was the first paper about long COVID symptoms that anyone had written. We pre-published it as such. We pre-published it very early, but it was sitting there for ages. And then we got in a fight with with 2 of the reviewers who wanted us to remove individuals who didn't have PCR tests and antibody tests because they couldn't be trusted, and we refused to do that. So we withdrew the paper. What I think is funny about that is, the paper itself now as a pre-publication has been cited 7 times. The impact factor of +1 is like 2.5. So, we've been cited 3 times as much as the average paper from +1 just as a pre-publication. And if that doesn't concern journal editors, that, there are other ways to make scientifically impactful work happen than subject yourself to, I don't mean to say that peer review isn't important, because I do think that peer review is important, but, when you send a letter to JAMA and they tell you that they're not going to publish it, and we initially sent that paper as a letter to JAMA, and they said, we're not going to publish this because it's not of sufficient interest. And then the next day they publish a case report of one doctor who happens to be on their editorial board reporting one patient, you know, with this new thing called long COVID. Come on, guys, you know, get your act together. And unfortunately, a lot of journals have lost sight of that. We've started to try and select our journals based on, you know, based on what we think is acting out of integrity and virtue now, as opposed to going for the high impact journals, because impact factor doesn't matter. What really matters is getting it out there and then sharing it widely for free where possible.
If you had infinite resources and could commission the research project of your choice into long COVID, what would it be?
Oh, dear God.
I might put you on the spot there a little bit. Apologies for that.
If I had infinite resources, I think that one of the areas that I'd really want to dig into that, I mean, there's so many areas. I'll start by saying that, but I will say that the one that I think is least likely to happen, and therefore I would most likely pour infinite resources into, is I've been chatting with a lot of people in the traditional Chinese medicine field, and I've been comparing notes with them. And, you know, they've been having, some of the practitioners I've been speaking to have been having good success in managing symptoms. And God, I would love to start to create consortiums where we can start speaking to Qigong practitioners, TCM practitioners, craniosacral practitioners, and pulling them into the conversation, because a lot of what they're doing is really, really working. And they're not getting a look in from the NIH or the CDC or probably, you know, the NHS, although I haven't been watching. And, you know, that would be, this is a crisis, and we got to look in all directions. And we have exactly zero funds to look in that direction, which is a real shame.
And I think both Asad and I can testify to the effectiveness of some of those treatments. We've both experienced some of that, and I completely agree. I would love to see some of that work validated by science and by results, because I also think it works.
Yeah, couldn't agree more. I mean, it was a TCM practitioner who got my heart rate that had been going from 140 for a week down to 80 in 2 hours. No drug has been able to do that. And certainly craniosacral therapy, breath work, these things do work.
Hope you found that interview with the great Dr. Putrino enlightening, because I certainly did. Our next episode, slightly later than originally advertised, is how to manage a return to work and at what point in your recovery you should attempt it. Until then, till next time.